Hello, good evening, dear friends. Today we are going to discuss brain surgical disorders, eMRCS question bank. Everyone will start reading the question and give the answer, and then we are going to discuss and clear everything about the answer and the related topics and the questions as well. For any question, just raise your hand, and between question we can discuss about your debate. Okay, let's start now. Our first question. Okay. تمام دكتور غادة تفضلي.
Yes, I'm just waiting for the screen for question.
Okay.
Yes, a 78-year-old man is brought to the emergency department police. He's found wandering around the town center and is confused. His family report that he's usually well apart from simple mechanical fall 3 weeks previously, from which he sustained no obvious injuries. What's the most likely underlying cause? Acute extradural hematoma, chronic subdural hematoma, subarachnoid hemorrhage, interventricular hemorrhage, acute subdural hematoma. Well, from the history, it's subdural hematoma. So it's either chronic or acute, but it's there is a history for 3 weeks. So I think it's a chronic subdural hematoma, and there is no neurological finding. So chronic subdural hematoma.
Okay.
Yes, I will go for chronic subdural hematoma.
Chronic
the second
subdural
choice.
hematoma. Okay. Let us see the answer. Dr. Jeff, Dr. Fatima, B. Anyone has different answer or another opinion? Okay. Exactly. This is an old patient brought to the emergency department by the police, found wandering around the town center and is confused. His family reports that he's usually well apart from a simple mechanical fall 3 weeks ago. This is so 3 weeks ago, and he started to have injury and have a problem after 3 weeks, and without any manifested injury on his head. So we are talking about simply when you are going to a trauma to the head. If a young patient and the trauma is recent within the same day or something like this, and with rapid deterioration, we suspect more an extradural hematoma. Okay. In our choices here, we have 2 subdural, 1 extradural acute. All as Dr. Ghada explained, she's very well explaining. This is after 3 weeks, you are not talking about any acute problem. Okay, so acute extradural hematoma is we exclude. Chronic maybe. Subarachnoid hemorrhage, this mostly cause sudden death or very rapid deterioration, and it's acute problem. Interventricular hemorrhage is not common in this age. And acute subdural hematoma, yes, it is a subdural hematoma, which is the most common in very old patients because there is a brain atrophy and the size of the brain inside the skull is less than the adult human. That's why in any trivial trauma in old age, it's very common to see in this age the subdural hemorrhage. Sometimes subdural hemorrhage is large enough to have problems within few hours, and this is the acute subdural hematoma. and sometimes it is sustained for a long time, slowly till it starts the patient to have or to be manifested by a problem. So here, subdural hematoma with a trivial trauma for a long time. So the patient starts to have the manifestation 3 weeks after the trauma. Okay, subarachnoid, we said this is sudden death. Interventricular hemorrhage, we don't see it in this age. And actually, to be clear, here is in our discussion, in our schedule, he wants you to know broadly that interventricular hemorrhage is very common in premature childs, premature infants, neonates, premature neonates. Sometimes he insists, he wants you to suspect this problem in any premature neonate.
An accidental injury,
accidental injury, and he sometimes reports no injury, but sometimes he say a premature and he still disturbed conscious level, and he wants you to put in mind as a doctor that interventricular hemorrhage is very common in this age group. Okay, sometimes you have a child, newborn. If you didn't put in your mind that she may have a neurological problem like interventricular hemorrhage, you will never reach a diagnosis in the clinical base or in the in your work life. Okay, and she said, what's the difference between acute and chronic? Okay, sorry, in the first few questions, sometimes we took long time just to explain some question. Okay, Dr. Nabaz.
Yes, sir. Thank you so much for the explanations. I wonder if anyone can exactly explain what is the time frame for which we can differentiate between acute or chronic to label the situation as acute or chronic.
Okay, because keep within 2-3 days. He will give you a long gap of time. He in all questions we will face, you'll find the man has an accident and went to hospital, or in history an accident yesterday or something like that. Within first 24 hours or maximum 48 hours, this is an acute problem. But after 3 weeks, I think it's a chronic problem.
Thank you so much.
Okay. Just there is no confusion here. The time frame will be long enough to make you not to confuse in the exam. Okay.
Okay,
welcome. So let's go for our next question. Okay, Dr. Fatima.
A 21 years old man is involved in a road traffic accident. After a transient period of concussion, he is found to have a GCS of 15 by the paramedics. On arrival at the hospital, he is monitored in a side room of emergency department. When he is next observed, he is noted to have the GCS of 3 and a blown right pupil. Which of the processes below best accounts for this deterioration? 1 is hydrocephalus, 2 intraventricular bleed, 3 subdural bleed, transtentorial herniation, and subarachnoid hemorrhage. Okay. So he has a concussion, initial GCS is good, but then deteriorate. So it's not hydrocephalus. There is no transtentorial herniation, no subarachnoid hemorrhage. So I will go with subdural bleed.
Okay,
or intraventricular bleed.
Subdural?
Or intraventricular.
Or intraventricular bleed. Okay.
Can be possibility, but I'm not sure about that.
Okay, anyone can has different answer, can write it in chat, please. Dr. Nabal, if you need to answer or to say anything, you can write in chat.
Yes, thank you, doctor. Really, my
Okay.
opinion is going for transtentorial herniation.
Okay,
Because,
you can, yes.
yes, because of an extradural hematoma, which has caused a pressure and causing transtentorial herniation. Because if you look, there is a blown right pupil. Blown
Yes.
right pupil,
Okay.
it means there is a compression of the nerve nodes, cranial nerves. 3.
Okay. Thank you, Dr. Nawaz. Okay, however, Dr. Nawaz, we like more that you write your answer in the chat, or you can send it by private, so we can give a chance for others to think about the answer, and then after I can open the mic of anyone if you want to answer and take the explaination. Okay, so you choose transtentorial. Dr. Jeff, choose C or D, the same like not C or D. Dr. Ibtihal, E, subarachnoid, but okay. D, Dr. Ismail, Dr. Amuj D.
I also
Dr.
say
Ghada,
D.
Dr. Ghada D. Okay.
Yes.
Let's go for this answer. Okay, the answer is D, exactly. Let's go for an explanation here. This is a young man has trauma. He went to the have a period of concussion. Everyone have the serial of any extradural hemorrhage, okay, or trauma in a young patient. Mostly in our discussions and in our schedule in the Royal College and our eMRCS, he will lead you in any trauma in a young patient to a manifestation and complication of extradural. And as this is broadly, and this is the most common, and this is resample more than 98% of the questions in the exam. Young patient head trauma equals mostly extradural hematoma with its manifestations and its complications and its picture. Any trauma in old patient, and he will give you a wide gap of age like 80, 90. This patient mostly will have subdural hematoma. When he asking about a neurological problem in a premature neonate, he mostly, I'm not saying he's 100%, he's mostly want you to think about interventricular hemorrhage. Subarachnoid hemorrhage has a different picture. He wants you to put it in your mind because it resembles more than 90 or 95% of patients, which is severe thunderclap headache and ended by fainting and sometimes sudden death even in young age. Okay, without trauma. Again, subarachnoid hemorrhage, severe headache, sudden severe headache, sometimes he tells blurring of vision, fainting attack, the patient comatose, and sometimes sudden death. Okay, even the patient is young age. Sometimes he tells you a player, football player, and he's fell down with severe headache and death. Okay, hydrocephalus, mostly it is a medical disease, and it is not common here, and maybe we only have one question about hydrocephalus because it is not very common. It is not common even with trauma. Sometimes it's common with some brain tumors, and it happens on a chronic or a long time scale. Okay, so let's go through our question and the answer. The answer is he's a young patient, has a traffic accident, and he passed through the 3 stages of the extradural hematoma. First stage is the concussion. Okay, here is the patient or the patient will pass through a stage of loss of consciousness, which is about few minutes, and it's due to the vibratory movement of the brain, which makes some neurological disturbance. and then the patient regain his conscious again, which is called the lucid interval, and this takes few hours, maybe up to 1 day, and sometimes they say up to 48 hours, okay, about 2 days, and then the patient go again for a sudden loss of conscious or gradual disturbance in his conscious level, and this is depends on the rate of bleeding of the extradural hematoma, and this is the stage of coma. So concussion, lucid interval, followed by coma or loss of conscious. This is the 3 stages. Put in your mind, this is stages of extradural hematoma. So the patient is 15. He is past transient period of concussion, which is loss of conscious. Then he went for 15 GCS by paramedics, and on arrival to the hospital, next observed in the noted to have a GCS of 3. He went again to coma, followed by blown right eye. This means this is compression on the eye globe from the brain, or from what's called transcendental herniation. This is a big issue, and we need to go back again for head and neck anatomy and explain what about the tentorium cerebelli, sorry, and when there is a compression from one side by an extradural hematoma, there is shift of the midline of the brain from this side to the other side, which makes the other half of the brain start to herniate through the tentorium cerebri. And this makes this picture of transtentorial herniation. Okay. Even if I don't know the answer, I'll go through our broad idea. Is it hydrocephalus? No, it is not with trauma. It's an interventricular bleed? No. It's most common in neonates, premature, according to our study. This put in your mind. Is this a subdural bleeding? Not with this age. This age 21, his young age. It is subarachnoid hemorrhage. There is no sudden death here or headache or something like this, because subarachnoid hemorrhage doesn't come with trauma. It's always a medical disease that comes with sudden severe headache followed by fainting attack or comatose or coma in any age. So by exclusion, we can go for transtentorial herniation, and this go with our scenario with the GCS3 followed by blown right pupil. Okay, is it clear or anything is not clear? Clear?
Yes, clear.
Okay.
Hello. Just want to ask a
Okay.
question.
Yes, okay.
Yes, for though it's clear. Thank you for explaining it. Yeah, I just want to differentiate it because I was a bit confused initially in differentiating between answer C and answer D. But I know some acute subdural can give a quick deterioration of GCS of theory, but I think it won't give a blown right pupils.
And it will not give us a lucid interval.
Yeah, it won't give any blown right pupils. Yeah, we should explain. Yeah, you are right. Yeah.
Okay.
I've understand it very well. Thank you very much. Yeah.
Okay, you are welcome. Okay.
Yeah, thank you. Yeah.
Okay. Okay, who's next?
Okay. A 28-year-old man is playing tennis when he suddenly collapses and has GCS of 4 when examined. What is the most likely cause?
Okay, without reading the answers.
Okay, it is subarachnoid hemorrhage.
Okay, this is a problem. This is the scenario which will come to you for a subarachnoid hemorrhage.
Yes.
Okay.
Yes.
This is the scenario for the subarachnoid hemorrhage.
exactly.
Is it clear now?
Yes, it's
You
clear.
see, Berry's aneurysm, exactly. Most commonly will be Berry's aneurysm. Okay.
Yes.
By the way, it's one of the easiest questions in the exam. No confusion. This is a typical scenario. Young patient, old patient, whatever the age, sudden severe headache, collapse, GCS4 without trauma.
Yes.
Okay.
Okay.
But the question will be more and more clear when we go through the question. Don't worry about that. I'm just explaining and give an idea about the most related questions that you will face. So I think now we are starting to clear everything. Okay.
Okay.
Okay. Next question.
A 53-year-old teacher is admitted to the vascular ward for a carotid endarterectomy. Your FY1 does a preoperative assessment and notes that there is a right homonymous hemianopia. There is no other neurology. What is the most likely cause? Lateral medullary syndrome, middle cerebral artery infarct, anterior cerebral artery infarct, cerebellar infarct, posterior cerebral artery infarct. Homonymous hemianopia is the clue here. So it is posterior cerebral artery infarct, most probably.
Your answer is
E.
E. Why? Did you choose this artery exactly?
To the it supplies the occipital lobe.
Yes.
So they've given homonymous hemianopia. So
and there is no, put in your mind, what about no other neurological?
No other neurology, yeah. So
okay,
it likely point towards that.
Okay, your answer is right. Exactly. This is the posterior cerebral artery infarct. I think I told you to try to know the blood supply for the brain, but I'll say
Yes,
it broadly here. Okay.
Okay.
In no details, just broadly, we have this is the brain. Okay. And this is the mid precentral postcentral gyrus, and this is, I like to do this.
Doctor.
Okay. So we have this septal. We have this here. We have this. Okay. What I'm doing now is, this is the green, is the anterior cerebral artery, and it's taking the edge of the cerebellar hemisphere, the upside and the inner surface of the brain. Okay, so if I make like this on the other side, and just imagine this is the middle, so we will have the green is here. So the anterior cerebral artery give us just the upper edge of the lateral surface of the cerebral hemisphere, followed by the inner surface of the brain. Okay. Any infarction here, he mostly will tell you there's a weakness of the lower limb much more than the upper limb, and sometimes you have a problem in the some problem in the frontal lobe, like some dissociative problem, behavioral problem, and something like this. Okay. The other one is the yellow, is the middle cerebral artery. Okay, middle cerebral artery. Mostly he will tell you the patient, and this is the most common and the biggest artery supplying the brain, and it has a very strong associated manifestation like paralysis, which will be mostly upper more than lower, and aphasia, because it's affecting
area.
the Broca's and vernix area. I think most two areas here are affected by the middle cerebral. So he will tell you just he has some aphasia and some problem in speaking. Okay.
Okay.
As he didn't, sorry. Okay. The last one here is the posterior cerebral artery, and this is the one supplying the occipital lobe, and it's completely away from the motor area, and so he will tell you in the exam the patient has no other neurological manifestation except of visual manifestations. Visual manifestation.
Yes.
Why I told just clear why I said here and the anterior. Why I said here in the anterior we have the more upper, more lower than upper, and in the middle more. Please, no one tries right. And in the lower more, and in the middle cerebral we have more upper than lower, because simply we can, as we remember before, when our bachelor degree and something like this, that the body is resembling from upward down in the cerebral hemisphere. Like here is the lower limb,
yes.
And then the body,
yes.
then the lower, then the upper limb.
And the face.
Okay. So
yes, exactly.
if we make like this, and make this is the anterior, so the lower limb will be more affected than the upper. And here, if we go for the middle, the upper limb will be more affected than the lower limb. Okay. This one.
Yes.
Then go for the occipital lobe. I think it's long if we want to explain why he said right homonymous hemianopia. Okay, we'll have many questions about the hemianopia, but I'm just want to explain. I think this is a big issue about how you can know the type of hemianopia, starting from the optic radiation, okay, followed by the decussation of the optic chiasma, and then go for the optic tract, then optic chiasma, then optic nerve, and then how the fibers here, some decussate here and some go here, and so if we have a problem in the posterior cerebral, maybe here and the left side, so we are going to cut all these fibers on the right side, so the patient have right homonymous hemianopia, right? Homonymous hemianopia. Okay, I think the visual defects is We discussed some about it before, I think so. In anatomy, I think we have many questions in this. However, we have many questions here we can discuss again. To go for chat. Okay. Is it clear why we did choose posterior cerebral artery?
Yes.
Okay. Next question. Dr. Ibrahim.
A 20-year-old man is admitted to the intensive care unit with an isolated severe head injury. A CT scan shows multiple intracerebral bleeds, but no midline shift. He is intubated and ventilated. His pupils are dilated and react sluggish to light. His heart rate is 50 beats per minute. Blood pressure 170 over 110. And his respiratory rate is set at 10 breaths per minute. The rising blood pressure is likely to be caused by this is Cushing reflex, and the reason is aortic and carotid baroreceptor no, cortisol stimulation no, renin-angiotensin no, sympathetic stimulation related to blood loss no, sympathetic stimulation related to increased intracranial pressure E. Is the activation of vasomotor center.
Okay. So here we are talking about, thank you, Dr. Rami. Welcome, Dr. Rami Aizat, one of our full eMRCS candidates, one of our genius orthopedic doctors in Oman. Dr. Rami. Welcome, Dr. Rami, for our discussion. Okay, so let's go for this question. Here is talking about hypertension patient post-trauma, CT, multiple intracerebral bleeds. That means, okay, so noisy for Dr. Rami. Welcome to our discussion. Okay, so we are talking about patient has multiple intracerebral bleeds, but no midline shifts. So we are expecting that this patient have brain edema and have increased intracranial pressure. So this patient will have what's called Cushing reflex. Cushing reflex, hypertension, bradycardia, and irregular breathing. Hypertension, bradycardia, irregular respiratory pattern. Okay. This is the answer, by the way. Is this right? How this happens? Anyone know how? What is the pathophysiology of Cushing reflex? Okay, Dr. Navaz. Would you like to explain or? Okay. Cushing reflex, this is brain ischemia. So will happen what's called increased sympathetic activity of the body. So will happen what's called increased peripheral increase for peripheral resistance and increase in the heart and increase the blood pressure for the patient, followed by increased sensitivity of the baroreceptors due to stretching of the baroreceptor and the aortic arch and the carotid sinus, which will lead to decreased heart rate. So the patient will have a low heart rate with hypertension. Okay. This is simply about the Cushing reflex. Patients have increased sympathetic, and they always say this is a mixed sympathetic and parasympathetic activity, because in the first you start in the increased sympathetic activity of the patient. So the patient will have hypertension, which will be sensitized by the baroreceptors and the aortic arch, leading to reflex bradycardia for the patient. So the patient will have hypertension, bradycardia, together with irregular respiratory pattern. Okay? Clear about the Cushing reflex? My voice clear? Any answer?
Yes, clear.
Okay, I just need someone to answer me. Thank you. Okay, whose turn now?
I think it's me.
Okay, Dr. Ibtihal, you can go.
25 years old cyclist is hit by a bus traveling at 30 meters per hour. He wasn't wearing a helmet and he arrives with a Gascoma score of 3/15 and is intubated. A CT scan shows evidence of cerebral contusion, but no localization clinical signs are present. What's the most appropriate course of action? Per-hole decompression, decompressive craniotomy, insertion of intracranial pressure monitoring device, administration of intravenous mannitol, parietotemporal craniotomy. Cerebral contusion, not localizing clinical signs. I think brain edema. Per-hole, no. Intracranial pressure monitoring device. I'm confused between B and C.
Okay, between B and C.
Yes.
Okay, so you have no evidence of any, till now you don't have wearing a helmet, GCS 3 intubated, CT scan, evidence of cerebral contusion, but no localizing clinical sign are present. Okay, he did a CT scan, okay?
Yes.
And he has no localizing clinical signs. Even he didn't mention that the patient have edema, brain edema, yes?
Yes.
He didn't mention that the patient have brain edema. If he mentioned, because he said CT scan shows, so he should tell you all the data about the CT scan, but what he said that the patient has cerebral contusion, but no localizing signs. So the patient is expected to have brain edema and increase in the intracranial pressure. So the best course of action here to insert an intracranial pressure monitoring device. This is not practical in our work maybe, but this is the policy in the UK in following a patient with no localizing sign. Because if we go for this is the answer, insertion of intracranial pressure monitoring device. Mini has answered. C. Yes, okay. Per-hole decompression, where exactly? I don't have a localized sign, decompressive craniotomy. He didn't mention that the patient has brain edema or diffuse hemorrhage or something like this. Administration of intravenous mannitol, the same. He didn't mention that the brain already have brain edema. And parietotemporal craniotomy is the same like per-hole or decompressive craniotomy. We don't have any localized lesion or hemorrhage, so we can go for this. Okay, so the best action here, as he didn't mention, if he mentioned that the patient has the CT showed brain edema, so my answer will be directed to administration of intravenous mannitol, because this is the first line we use to decrease brain edema in patient with GCS 3 out of 15 and intubated, and the CT shows brain edema. Okay.
Okay.
Thank you. Okay, next. Dr. Mon?
What type of visual field defect is most likely to be noted in a patient with a craniopharyngioma? Lower bitemporal hemianopia, upper bitemporal hemianopia, right superior quadranopia, right homonymous hemianopia, and left homonymous hemianopia. I think the answer is upper bitemporal hemianopia
Yes.
because it is
Upper
a
or lower?
I'm not clear about between upper and lower, but what I know is that it can be bitemporal hemianopia.
Bitemporal hemianopia, but you are not sure about upper or lower.
Yes, sir.
Okay. Let's imagine this is the optic tract, optic nerve, and this is the chiasm. Okay, this is the chiasm. Any lesion in the chiasm, okay, as we know, could cause us what's called bitemporal hemianopia. Clear?
Yes.
Okay, but we have two lesions. Have lesion compressing from above, and we have another lesion compressing from below. Okay, when a lesion compressing from above, okay, this the lesion is craniopharyngioma. Lesion compressing from below is the what? Pituitary tumor. Pituitary tumor. Okay. This is compressing. So we have the optic chiasma too, compressing from above and compressing from below. Let's imagine the eye, and they have some fibers coming from above and have some fibers coming from below. Okay, so if I cut these fibers, so this part I will not see. So something compressing from above. Okay, so this part of the vision of the globe inside will not see. But what will not see? It will not see the lower part. Okay. Is it clear? In our eye, like a circle, if you just imagine that the eye is a circle, okay, so we did like this part, see this one, and this part, see this vision, this part, see this vision. We go perpendicularly in the circle. Clear? Anyone just answer me, is it clear or it is difficult?
Yes, it's clear.
Can you explain again?
Explain again. Okay. The eye. Okay. Again. If This is the eye. Again, I'll draw only one eye, and I'll go for, and this is the nose. Sorry, this is the nose. The eye is a ball, okay? And every part of the ball see a specific part of the vision, okay? So this part may be the outer part of the ball. The outer part of the ball sees the inner part of the vision, and the reverse, the inner part of the ball sees the outer part of the vision, okay? This is a ball. Look at this as a three dimension. So a ball, this is the part, outer part can see the inside vision, and the outer and the inner part sees outside vision. So if I have the optic tract coming like this. Some fibers coming from the optic tract like this. Okay, and then we will continue with another color to go like this, supplying this part, and the other is supplying this part. But this is only one tract, okay? Supplying the outer part of the ball, the outer part of the ball, which should be like this. If I want to cut, it will be like this. Okay, like this. So if there is something compressing from above here and compressing the upper fibers, it will go for this fiber that can't see. That's normally its vision is like this. Okay. So compression from above will give me blindness in the lower bitemporal lower. Compression from above, sorry. I will not see the lower bitemporal hemianopia, lower bitemporal, sorry, lower bitemporal will be outside, lower bitemporal hemianopia. Okay. If the compression is from below, so I will lose this part of the fibers, which give me the vision of the upper part, whatever where is the circle. I think you are confused, yeah? Because this is a big issue if you want to just yes, to explain the visual fields and how we can see just to have a 3D imagination about the fibers and where to go and coming from where. We can do a special, got it? Okay, I hope most of you got it. If no one still not got it, we can explain it again. The answer here is lower bitemporal hemianopia. Just know it, put it in your mind. If compression from above, he will not see below. If compression from below, he will not see above. Okay, keep it in your mind just for now. Any compression on the optic chiasm, we have two lesions, one coming from above, which is the craniopharyngioma, compressing the optic chiasm. Okay, we all agreed that optic chiasm lesion will go for bitemporal hemianopia. bitemporal hemianopia. If from above, we will not see below. If from below, we will not see above. Okay? Clear? Clear. Okay. Next question, I think Dr. Dr. Nabazi wants to participate with us. Okay, you can go if it's your turn.
Thanks. I'm not sure really, is it my turn or not, but I will go through.
I don't know. I think it's your turn. You can go.
Thank you. A 52-year man is admitted to the vascular ward for an amputation. The patient complains of unsteadiness. On further examination, you detect right facial numbness and right-sided nystagmus. There is sensory loss of the left side of the body. What is the most likely lesion? So here we have a 52-year-old man admitted to the vascular ward for amputation. The patient complains of unsteadiness, loss of balance, and on further examination, you detect right facial numbness and right-sided nystagmus. There is also sensory loss of the left side of the body. What is the most likely lesion? Lateral medullary syndrome, posterior cerebral artery infarct, pontine infarct, lacunar infarct, and anterior cerebral artery infarct. Since there is a lack of unsteadiness, and there is also nystagmus, these are related to the cerebellum. I guess it would be posterior cerebral infarct, as
You said
supplies.
You said it is related to the cerebellum.
To the cerebellum or the medulla.
So why you choose posterior cerebral artery?
Because it supplies through inferior peduncular arteries or some sort of like that.
No,
Maybe the
posterior
answer.
Posterior cerebral is the terminal branch of the vertebral artery.
Yes.
Or the circle of Waltz.
Yes, but it also there is a loss of sensation on the left side of the body. So that
okay, but you have unsteadiness.
Yes.
Okay.
You have unsteadiness.
Numbness. You have right-sided nystagmus.
Yes. I think this is a syndrome. Mostly, it could be lateral medullary syndrome. So this will be my final answer.
Okay. Exactly. Anyone has different answer or any other thing? Most of us, Dr. Ragad, Dr. Ibrahim, Dr. Ibtihar, all said A. Yes, okay. This is the case which is a cerebellar lesion, okay, or what's we call cerebellar ataxia, which is manifested by what we say Danish syndrome, which is gives you this is the endocrine ataxia, which is the unsteadiness, nystagmus, here, instability. I can't remember the other Danish syndrome. Okay, this is the picture of the cerebellar ataxia, and this is here what we say here. He terminate or he give it the terminology of the lateral medullary syndrome. Posterior cerebral artery infarct will give you a visual problem, as we answered before. Pontine infarct, we don't have any questions here concerning the pontine, but mostly he will tell you a pinpoint pupil, one of the most common manifestation for pontine infarct. Lacunar infarct, we have a specific criteria for it. We will face it in the next few questions. Anterior cerebral artery infarct, we have a weakness in the body, in the motor movement and in the motor function of the body, in the picture of weakness in the lower limb more than the upper limb. Okay. Okay. Is it clear about lateral medullary syndrome?
Yes.
Okay. Simply, every one of these has its a specific manifestation. Posterior cerebral vision, pontine pinpoint pupil. Lacunar, we have the sensory problem we will face in the next few questions, and the anterior cerebral artery and the middle cerebral artery we explained in the start of our discussion. Okay. So here is tell you a combination of ipsilateral ataxia, nystagmus, dysphagia, facial numbness, cranial nerve palsy with contralateral hemisensory loss indicates this diagnosis, which is the lateral medullary syndrome. Okay, I think we will start from again, Dr. Ghada.
Okay. 18-year-old boy falls off balcony and hits the right side of the head. He is admitted to the emergency department and has a Glasgow Coma scale of 10. He is admitted for observation and over the following 12 hours develops an increasing headache and confusion. CT scan shows a crescent-shaped collection of fluid between the brain and dura and associated midline shift. What's the most likely diagnosis? Straightforward extradural hematoma. Acute extradural hematoma, yes. C. There is a crescent fluid collection between the dura mater and the brain. So it's limited by the suture line. Acute extradural hematoma. Subdural.
Sorry, I'm muting.
Okay.
Okay, so I didn't read, sorry again, I didn't read about the CT scan, just I paused the scenario as a straightforward scenario from hitting and GCS and then confusion, and I didn't read the CT, and I even mentioned even if he didn't mention the CT, it is most commonly it is an extradural hematoma, but here he mentioned that the CT give us a crescent shape.
Crescent
And this
shape.
is this, yeah, crescent shape. That's a little
Yes.
bit confusing. So
tricky.
this is the key word here. This is subdural, and the lens shape is the extradural.
Yes.
Okay. I think it's clear. And thank you for all those who just see it and see between dural and skull, extradural, dural and brain subdural. Yes, exactly.
Yes, thank you.
Okay.
Yes.
Okay.
A 53-year-old teacher is admitted to the vascular ward for a carotid and arterectomy. Your F1 does an preoperative assessment and notes that there is a right homonymous hemianopia. There is no other neurology. What is the most likely cause?
I think this is a repeated question.
Yeah, this is already done.
Okay, I think this is a repeat and this is a mistake by the eMRCS, by the way, because this is another number 6 out of 27. So this is a repeated question. I think we answered this was the first question about the posterior cerebral artery infarct, which affect the posterior or the occipital loop. So the patient will be manifested by only visual problems without any other neurological problems. Okay, you can go for the next question, Dr. Fatima.
Yeah. A male infant is born at 28 weeks gestation by an emergency cesarean section. He is taken to the theater for a colostomy due to an imperforate anus. He initially seems to be progressing well. However, he begins to develop decerebrate posturing and is becoming increasingly obtended. What is the most likely underlying problem? Extradural hematoma, subarachnoid hemorrhage, acute subdural hemorrhage, intraventricular hemorrhage, chronic subdural hemorrhage. It's intraventricular hemorrhage, as we discussed already. It's premature.
Okay, I think it's clear now about, he will tell you this is a premature newborn
Infant.
and then infant and represented with
Decerebrate posture.
decerebrate posture, any neurological problem. He wants you to put in your mind that this problem is very common in premature interventricular hemorrhage. Okay.
Is it the same floppy baby syndrome?
Floppy baby syndrome.
Yes.
Maybe, I think, but I didn't see even in recalls, or I didn't see the expression. Maybe in
Yes.
neurology it is the same, but I didn't see the terminology here,
Okay,
even
fine.
in eMRCS or in the recalls. Maybe it's the same.
Okay, fine. Thank you.
Okay, if you are sure, you can tell us about, or you can send on the group about the floppy baby syndrome.
Okay, I will
maybe.
search for it. Yes, I had a
Okay.
question. Yes. Okay.
Okay.
Thank you.
Okay, Dr. Nabaz.
Yes, sir. I just want to add one information. Really, those children will present like this. They will be brought by their parents to the pediatric emergency department with dystonia. The father and mother, they complain that the child is showing rigid limbs, upper or lower. But when they bring the child to you, you will see the child is pale. So by this, you suspect intraventricular hemorrhage.
And premature child or neonate?
Sometimes in neonate, mostly in neonate.
Okay. Okay, here is, as I told you, he will be clear here that he wants you to put this in your mind. In prematurity, you may have this problem. He's talking about prematurity here. He will be clear with you. He will not confuse you by a syndrome that may happen in a child. In a child, like the picture you told us about.
Just what I wanted to
if we find,
add,
yeah.
was the pallor So if you suspect a child
Yes, with pallor. With pallor, yes. A neurological problem with pallor.
with
Yeah.
pallor, neurological problem with pallor, recent, with no trauma in a neonate. Think about this.
Okay. Thank you, Dr. Nawaz. Who's next?
Okay. A 33-year-old lady develops a thundercalp headache and collapses. A CT scan shows that she has developed a subarachnoid hemorrhage. She currently has no evidence of raised intracranial pressure. Which of the following drugs should be administered? Non-atenolol, labetalol, nimodipine, mannitol. Nimodipine.
Nimodipine. Okay. You know what is nimodipine?
Yes, it is calcium channel blocker.
Okay, this is a calcium channel blocker, especially for
aneurysm.
And yes, and brain aneurysm mostly. Okay, a very common question, by the way, here and in part B. Suspected complete history case, you will one of the history stations of part B. One of the questions you have to ask for the patient, or the patient will tell you, guide you, I have a thunderclap headache, then I started to get a disturbed conscious level, and you will be asked about the management and the treatment, and you have to mention the nimodipine by name as a calcium channel blocker used for suspected breast aneurysm in patient with rupture or rupture vena aneurysm. Okay. Okay, Dr. Ibrahim.
Today, all is noted become floppy and unresponsive. What is the most likely cause? Interventricular hemorrhage. Repeated idea.
Okay, today all premature neonate born by emergency cesarean section noted to have a floppy and unresponsive. Yes, as Dr. Ghada said, floppy. So this is a floppy baby syndrome and
Yes.
unresponsive. So
Hypotonia.
this is hypotonia. So this is the interventricular hemorrhage as we discussed in this time. Okay, next question.
A 65-year-old male with no nasopharyngeal carcinoma presents with double vision over a few weeks. On examination, is found to have left eye proptosis and it is down and out. He reports pain on attempting to move the eye. There is absent corneal reflex. What is the most likely diagnosis? Posterior communicating artery aneurysm, cavernous sinus thrombosis, optic nerve tumor, migraine, and cerebral metastasis. So my answer is B, cavernous sinus thrombosis.
Okay, any other answer?
Nasopharyngeal carcinoma, left eye ptosis, double vision, and absent corneal reflex.
Okay. This is a picture of cranial of cavernous sinus thrombosis or cavernous sinus syndrome, especially if the craniopharyngioma is immediately related to the cavernous sinus, and the patient will presented with proptosis, psalmoplegia, and I think the third one, sorry. What is the third manifestation of proptosis, of psalmoplegia, and another thing, I think, third manifestation of cavernous sinus thrombosis?
Absent reflexes. It's mentioned there is absent corneal reflex. It's related
I
to
think
the
yes, many
trigeminal nerve.
many manifestation, but I think the most of them is the proptosis and the
Double vision.
double vision.
Diplopia, yes.
Okay, so can anyone remember what is the structure passing through the cavernous sinus?
Internal carotid
Third.
artery and cranial nerve 6 abducent.
Yes.
Inside
and
the
lateral wall,
sinus, internal carotid artery.
In the lateral wall, there is oculomotor nerve, trochlear nerve, ophthalmic nerve, and maxillary nerve.
Exactly. To remember, because this is very important in anatomy. Okay, this is the cavernous sinus. We have the internal carotid. We have the decussate inside, and then we have 3, 4, and 1 and 2 from 5. Okay, V1 and V2. Right? 3, 4, V1 and V2, and then 6 cranial nerve.
Yeah.
That's why you have the eye looks down and out because of paralysis of these nerves supplying the extraocular muscle, trochlear and oculomotor trochlear, especially the trochlear and the abducent nerves. Okay, clear? Yes. Here is the anatomy again. Oculomotor trochlear, ophthalmic, and maxillary, plus the abducent nerve and the internal carotid. Okay, next question.
A baby is brought to casualty unconscious and in a vegetative state. She has cigarette burns on her leg. What is the most likely underlying injury? Acute subdural hematoma, chronic subdural hematoma, acute extradural hematoma, diffuse axonal injury, subarachnoid hemorrhage. I think diffuse axonal injury.
Exactly, this is they say the shaken baby syndrome. One of the babies or child abuse. Sometimes the child abuse. Shaking the baby makes deceleration and acceleration of the axons of the brain, and this is the same idea of the concussion, by the way. The same idea of the concussion. Concussion equals diffuse axonal injury. Sometimes the vibration makes this problem, and the patient lost conscious for a few minutes or up to 1 hour, and then go back again for normal conscious level because of the axonal injury or diffuse axonal injury, which is sometimes still due to deceleration or acceleration of movement of the skull, which make a movement between the gray matter and the white matter because the difference in the density of these two layers of the brain. And this is the same idea of the brain concussion, by the way. Okay. Next question. Who?
Would it be me, sir?
Okay, Dr. Nawaz, you can go.
Yes, thank you. A patient is referred to due to the development of a third nerve palsy, that is oculomotor, associated with a headache. On examination, meningism is present. Which of the following diagnoses need to be urgently excluded? Weber syndrome, internal carotid artery aneurysm, multiple sclerosis, posterior communicating artery aneurysm, anterior communicating artery aneurysm. So there is third cranial nerve palsy, oculomotor, and there is headache with features of meningism. That would be I'm not sure really.
Who has answer?
Posterior communicating artery aneurysm.
D.
Dr. Ibrahim?
I think D.
Okay. Okay, so this depends on the anatomy, and third nerve palsy, which is a premotor nerve, and so exactly we are talking about the posterior communicating artery aneurysm. Just put it in your mind that causes a third nerve palsy and headache. So we are talking about as an aneurysm or subarachnoid hemorrhage. Okay, internal carotid artery, no, it's maybe outside the brain, so it will not go for the third nerve palsy. Weber syndrome, yes, it is not. Multiple sclerosis is the same. So we are talking about aneurysm between the anterior communicating artery or the posterior communicating artery. So the most common here is the posterior communicating artery, which equals the painful third nerve palsy. Painful third nerve palsy equals the posterior communicating artery aneurysm. Okay. Some questions you will find that just has no related to other questions that he wants you to know this. Painful third nerve palsy equals the posterior communicating artery aneurysm. And it is not so common. Next question, I think we'll start from Dr. Ghada again.
Okay. 53-year-old man is admitted to the vascular ward for carotid and arterectomy. The CT head report confirms a left parietal lobe infarct. What type of visual field defect might be noted? Right inferior quadranopia, right superior quadranopia, right heminomus hemianopia, left superior quadranopia, lower bitemporal hemianopia. Okay, parietal, bits inferior on the opposite side, right inferior. Okay, right inferior quadranopia, A.
Right inferior quadranopia. Why?
Parietal infarct, and it causes the lower fiber cut, and so it's on the opposite side, it's left, so the loss from the right, so right
Yes.
inferior quadranopia.
So this is a left problem before the chiasma, so it will affect the right side. Okay.
Okay.
This is the start. So we are talking about right. It is not bitemporal because it is not in the chiasma. We said only in
Not
the chiasma
chiasm.
because the bitemporal hemianopia, we have a right or left. So we said right. So it is right superior or right inferior. Okay. This is what we are
parietal
talking
inferior.
about. Parietal inferior because it cuts the upper fibers, not the lower fibers. Okay. Simply, we are talking about the brain again. This picture, I know that you get bored from this picture. Okay, and then the fibers coming from the brain as I imagine it. Okay, this is the occipital lobe, and the fibers coming like this. Till it decussate here to make the optic chiasm. So if I remove the parietal fibers, so I am removing the upper fibers, so this will give me inferior problem, exactly as we said about the optic chiasm. Okay, if I get the temporal, if I cut the temporal fibers, okay, it will give me a superior, right, superior quadranopia. Clear?
Okay.
This is broadly I understand like this, because the same what I said about the optic chiasm. If I compress from above, I lose the below. If I compress from below, I lose the above. The same here. If I compress from above, which is the parietal lobe, I lose the inferior vision. If I compress from below, which is the temporal, I lose the upper vision. Just keep it simple like this. Okay. Clear?
Okay.
So this is a right inferior quadranopia, as Dr. Garda said, because we, after it coming from the opposite side, then decussation happened in the part of the fiber decussate in the optic chiasma to go for the other side. Okay, to give the temporal part of the other side and the nasal part of the same side. So it will give us a right or left according to the opposite loop. So here he tell you superior equal temporal, inferior equal parietal, like X. Okay.
Okay.
Okay. Next. Next, Dr. Fatima. Okay.
52 years man is admitted to the vascular ward for an amputation. The patient complains of unsteadiness. On further examination, you detect right facial numbness and right-sided tiredness. There is a sensory loss of left side of the body. What is the most likely cause? It's lateral medullary syndrome. I guess we had this question before. Kind of this question.
You lucky with repeated questions, yeah? This is the second one with you, yes?
Yeah.
And by the way, it is another number completely. So it is a problem in the eMRCS and a problem in you. It is not in me, yeah?
But that is like contralateral sensory loss. Here it says, they just changed the wordings here. It's a sensory loss.
Some change here. You know, they said here some facial numbness, right-sided nystagmus and steadiness. Okay. And sensory loss on the left side of the body. Okay. So the same explanation. This is a lateral medullary syndrome, but this is a very close question. So you will take another question. You will not skip. Oops, even the next question is solved. So okay, you can read it.
Okay. A 32 years old rugby player is crushed in a scum. He is briefly concussed, but then regains consciousness. He then collapses and is brought to emergency. His GCS on arrival is 6 out of 15 and his left pupil is dilated. What is the best course of definitive management? So he has a concussion and then collapse. Then GCS is 6 out of 15 and pupil is dilated. So the best management is it says parietal temporal craniotomy. So is it something is compressing here? So that's why he went to that craniotomy. And this.
Okay, the patient has extradural hematoma manifested by the lateralization, which causes the left pupil to be dilated. So we go for a decompression craniotomy, which is a parietal-temporal craniotomy to decrease the compression. He said here a left pupil and right pupil because he won't tell you this is one side. This is a parietal problem, compressing one side of the brain, so causing one side of the cranial nerve or the oculomotor nerve to be compressed. So the patient has a left pupil is dilated. So here we don't go for monitor, we don't go for posterior fossa craniotomy. This is a parietal problem. So the most accurate here is the parietal temporal craniotomy to decrease the extradural hematoma. Okay. Okay. Next question.
Yes. A 23-year-old man was driving a car at high speed whilst intoxicated. He was wearing a seat belt. The car collides with a brick wall at around 140 km/h. When he arrives in the emergency department, he is comatose. His CT scan appears to be normal. He remains in a persistent vegetative state. What is the most likely underlying cause? Extradural hemorrhage, subdural hemorrhage, subarachnoid hemorrhage, intracerebral hemorrhage, diffuse axonal injury. Okay. This is diffuse axonal injury.
Exactly the same what we said. If I have nothing with the CT and this patient is still in the vegetative state, he is in the state of concussion.
Yes.
Okay. Diffuse axonal injury or concussion or acceleration, deceleration, or sometimes they explain it with the vibratory movement, the severe or the rapid vibratory movement of the axons of the brain nerve cells cause this problem because the difference between the density of the gray and white matter. That's why when you move the brain suddenly in a concussion, in the concussion case, makes this diffuse axonal injury. Okay. The same equals the concussion stage. Okay, next question.
A middle-aged lady is brought to the clinic by her husband, who has noted a change in her appearance. She finds removal of rings difficult. Her shoe size has changed, and photographs show the marked change in her appearance. Which of the following is most likely to be identified on neurological examination? Binasal hemianopia, bitemporal hemianopia, inferior quadrantopia, homonymous hemianopia, unilateral loss of vision. Bitemporal hemianopia.
Okay. Here is the problem he is talking about.
Pituitary adenoma.
Pituitary adenoma. The patient is represented with
acromegaly,
gigantism, and some neurological manifestation. Change in appearance and finds her rings difficult. Shoe size has changed. So this is bitemporal hemianopia. More superior or more inferior?
Superior defect.
More superior defect. More superiorly, because the compression is from below. Okay. I think it's clear about the optic chiasma now. Any lesion will cause bitemporal hemianopia, and we can know it is more superior or more inferior by the compression. If it is craniopharyngioma, it will compress from above. If it is pituitary adenoma or pituitary tumor, it will compress from below. Okay, next question.
A 42-year-old woman is admitted to the vascular ward for endarterectomy. A CT report confirms a left temporal lobe infarct. What is the most likely visual defect to be encountered? Right homonymous hemianopia, right superior quadranopia, right inferior quadranopia, left superior quadranopia, left homonymous hemianopia. She has a left temporal lobe infarct. So it is right superior quadranopia B.
So this is a temporal.
Yes.
B.
Yes, right
This
superior.
This is a temporal lobe lesion. So this is the lower fibers, yeah? So it will affect the superior vision. And this is here left temporal. So we are on the left temporal, so we will affect the right side. So this is left lesion will affect the right side. And this is the lower fibers in the temporal lobe. So it will affect the superior quadrant. So it will be right superior quadranopia. Is it clear now?
Yes, Dr. Rami, thank you.
Yes.
I think it's clear with this diagram. Maybe it is wrong. Maybe it is wrong diagram, but I'm sure mostly it's right. But if you just know it simply by simplify your question by this diagram, right superior quadranopia.
Yes.
Next question.
A 48 years old type 2 diabetic complains of numbness in his left arm and leg. Otherwise, there are no other neurological signs. What's the most likely cause? I think lacunar infarct.
Yes, just numbness, sensory manifestation in the arm, the upper and lower half of the body. It is without any motor manifestation is the lacunar infarct syndrome. Just know it like this, okay? Some syndrome manifested by this isolated hemisensory loss of is a feature of lacunar infarct, and just know it like this. No other related question will confuse you about this. Okay, if he mentioned lower or upper or lower motor deficit, you go for the anterior cerebral or posterior cerebral according to, or middle cerebral, sorry, according to the lesion. If he mentioned visual problem, you go for the posterior cerebral. Okay, next.
A
I think
50-year-old.
it's me now.
Oh, sorry.
Okay.
No, Dr.
No,
Nabal.
no.
Okay.
Yes, okay.
Dr. Nabaz, okay.
Thank you. A 50-year-old lady is admitted having fallen down some stairs, sustaining multiple rib fractures 36 hours previously. On examination, she is confused and agitated and has clinical evidence of lateralizing signs. She deteriorates further and then dies with no response to resuscitation. What is the most likely explanation? Intraventricular hemorrhage, acute subdural hemorrhage, chronic subdural hematoma, subarachnoid hemorrhage, extradural hematoma. So it's a lady with 50 years falling down. So there is history of trauma. There is multiple rib fractures, and within 36 hours happened. There is confusion, agitation, lateralization signs. She deteriorates further and dies with no response to resuscitation. So, subdural hematoma. So I would go for extradural hematoma.
Extradural hematoma. Any other answer?
Acute subdural hemorrhage.
Acute subdural hematoma.
Acute subdural hemorrhage.
There is lateralizing sign.
Yes, exactly.
And
the
she's
history is
within 36 hours. And the age is 50. It's middle age, not so young.
yes.
And there's history of trauma. There's multiple fractures and deterioration within 36 hours.
Yes,
So I think it's acute subdural hemorrhage.
Yes, exactly. The history of extradural hematoma comes more with the young age and with rapid
interval.
Yes, with lucid interval, and he will give you the full history on the full course of the loss of conscious and then become good and then loss of conscious again.
Yes.
Rarely I didn't see that cause this sometimes because it is at least still restricted by the dura mater. But in the subdural hematoma, the age will be much more advanced age than the young patient, and the course of the deterioration will go slowly. Okay, you can notice in the extradural hematoma, loss of conscious, go back to normal, lucid interval followed by sudden loss of conscious and sudden coma again. Okay, but in the subdural hematoma, he will tell you confused, agitated, then start to deteriorate slowly till death, and this is a very common story and a very common scenario in the subdural hematoma. This is acute. This is 36 hours. We're still in the scene of the trauma. Okay, I think Dr. Nabaz, it's clear now about the duration between the chronic and the acute. Okay.
Yes, thank you so much.
Okay. So this is acute subdural hemorrhage. Not subarachnoid, not interventricular. I think we know the scenario now. And we are confusing between acute and chronic and now we do it. Extradural hematoma has a different scenario completely than the gradual deterioration. Okay, Dr. Ghada.
2-year-old boy presents with vague neurological symptoms and is managed with an MRI of the brain. This demonstrates a tumor that's located in the floor of the fourth ventricle and extends through the foramen of Magendie. What's the most likely diagnosis? Glioblastoma, CNS lymphoma, ependymoma, schwannoma, meningioma. Extending in the floor of the fourth ventricle. I think it's the glioblastoma, which is the most common from all others.
Most common tumor, glioblastoma.
Yes.
In a 2-year-old child.
I'm not sure.
Nabaz.
Yes, since it's arising from
Dr. Nabaz, wait, please. We don't go forward for the answer. We just slowly start to explain and then tell the answer. I know you know the answer. Okay. Just wait. I just want to explain something and then we can go for the answer.
Okay.
Okay. Sorry for this. I'll let you tell
Okay.
the answer, but I just want to explain something. Okay. Mini starts to answer. Okay. What is the most common? What is the most common tumor in children?
I think astrocytoma in children.
Astrocytoma, followed by
medulloblastoma.
Medulloblastoma. Before it was medulloblastoma, but now proven that astrocytoma is much more. In adult,
glioblastoma.
What is the most common?
Glioblastoma.
Glioblastoma. And the glioblastoma multiformant is the most aggressive one. Okay.
Yes.
Another information, but I didn't see any question about it, which is tumors, the site of tumors in children and in adults. About the tentorium cerebelli, he said in children it's most common below the tentorium cerebelli, infratentorial, and in adults most commonly will be above. Okay, supratentorial. Okay, this is some broad idea about tumors in the brain. Okay, Dr. Nawaz, what do you expect about the answer?
Yes, thank you, sir. Really, if you go through the options, giving the history or the diagnosis, it says arising from the ventricle. The ventricles are lined by ependymal cells, so it will be likely to be ependymoma. Schwannoma, schwannoma mostly arises in the internal acoustic meatus from the cranial nerve 8.
Yes.
Mostly. And meningioma arises from the meninges, from the dura, and glioblastoma arises usually within the parenchyma of the brain. So most likely.
Exactly. So the tumor coming from the meninges, from the the ventricles, is the ependymoma. Ependymoma or ependymoma. Okay. This is the most important things we mentioned about tumors. What is the most common in child? What is the most common in adults? What is the most aggressive? The site, I didn't see it before, even in recoils, but just put it in mind. Maybe in old recoils we didn't, I don't have, but maybe starting from 2012, I didn't see this in recoils.
Okay.
Okay. Next question, Dr. Fatima.
Yeah. 25 years old female with a history of bilateral vitreous hemorrhage is referred with bilateral lesions in cerebellar region. What is the likely diagnosis? Neurofibromatosis type 1, neurofibromatosis type 2, tuberous sclerosis, von Hippel-Lindau syndrome, and sarcoidosis. Okay. So it's a young female with bilateral vitreous hemorrhage, bilateral lesions of cerebral regions. So tuberous sclerosis is out because it has a totally different manifestation. Neurofibromatosis should have
This is a picture of a syndrome.
Yeah, so it's a von Hippel-Lindau syndrome actually, because neurofibromatosis is also out in here.
Is?
Neurofibromatosis has the other things as well. So I'll go with von Hippel-Lindau syndrome.
Yes, exactly. This is a syndrome, and when it comes in the exam, it comes with a combined vitreous hemorrhage with bilateral lesions in the cerebellum, because it is multiple hemangioma in the eye or in the retina and in the cerebellum. This is the von Hippel-Lindau syndrome. Okay, this is retinal and cerebral hemangioma are the key features of von Hippel-Lindau syndrome, and it's happened due to abnormality in the von Hippel-Lindau gene. Von Hippel-Lindau gene, okay, and this is a preneoplastic, by the way. This is all about von Hippel-Lindau syndrome, and we don't need to know any other information, and this is the only question we see about it, by the way. Sometimes just put it in your mind, it is autosomal dominant, and the VHL gene, which is from its name, have the abnormality in its gene. Okay. Next question.
Okay. A 30-year-old woman is injured in a skiing accident. She suffers a blow to the occiput and is concussed for 5 minutes. On arrival in ED, she is confused with GCS 10 out of 15. A CT scan shows no evidence of acute bleed or fracture, but some evidence of edema with the beginnings of mass effect. What is the best course of action? Administration of intravenous mannitol, administration of intravenous furosemide, parieto-temporal craniotomy, posterior fossa craniotomy, bar hole decompression. Okay, no evidence of acute bleed or fracture, but some evidence of edema with beginnings of mass effect. Administration of intravenous mannitol.
Exactly. I think we mentioned this in one question before, and we said when he tell you the CT has no problem, and unless some discrete hemorrhage or some cranial contusion, what is the next step is to do interventricular monitoring of the intracranial pressure or intracranial pressure monitoring by a probe. If he already mentioned that the patient has edema, so you have to go for intravenous mannitol as decreasing the edema of the brain, and this is the most common infusion we give in patient with brain concussion or brain edema. Okay. Nothing we craniotomy or posterior fossa craniotomy or birth hole, all we don't have any localized lesion or bleeding. Okay, we just have a brain edema, so we don't give furosemide for brain edema, we give mannitol for brain edema. Okay, next question.
A 28-year-old man falls and hits his head against a wall. There is a brief loss of consciousness. When assessed in accident and emergency, he is alert and oriented with Glasgow Coma scale of 15. Imaging shows no fracture of the skull. What is his risk of having an intracranial hematoma requiring removal? A, 1 in 6,000.
Okay, this is some numerical question, and I didn't see in any exam. And by the way, I'm sure that all these numbers now, any values or numbers or rates are not very common in the exam. Okay, if you want to just take an idea about this table, concussion with no fracture, skull fracture, and oriented will be one out of 6,000. Concussion with no skull but not oriented one. If you want to take an idea, just I think it will be maybe the first and last one. Okay. If you can keep it all the table, no problem, you can keep it, but it's one of the question is not common in the exam, and I didn't see in any recall before. Okay. Okay, next question.
A 50-year-old alcoholic man attends the emergency department. His main reason for presenting is that he has no home to go. On examination, he has no evidence of involvement in recent trauma. Skull X-ray fails to show any evidence of skull fracture. He is admitted, and 12 hours following admission, he develops sudden onset headache, becomes comatose, and then dies. What is most likely diagnosis? Acute extradural hematoma, chronic subdural hematoma, subarachnoid hemorrhage, intraventricular hemorrhage, and acute subdural hematoma. He doesn't have evidence of recent trauma. Skull fails to show any fractures, so sudden headache, and it is subarachnoid hemorrhage. C.
C.
Yes, no history of
Straightforward.
trauma. Yes. No
Straightforward.
trauma.
You said yes. Straightforward. Whatever the scenario we tell you, just want you when you see a patient, severe headache, comatose, and sometimes die. This is a case of arachnoid hemorrhage or subarachnoid hemorrhage. You have to put in mind this picture, by the way. I can remember before, immediately after my Part B exam, I have in the clinic, I did see the same picture, but the patient didn't die. A patient was waiting in the waiting room for another clinic, but beside me, and she is about 55 years, and she's hypertensive, and then started to shout with a very loud voice, a very loud voice, and screaming, and with severe headache and some blurring of vision, and she started to get drowsy and dizzy, and then she's transferred direct to the ICU with arachnoid or subarachnoid leakage, aneurysm leakage, by the way. But thanks that she didn't die, and I did see her about 2 weeks later because she is improved with medication, and I don't know exactly what did neurologist did, but I did see this picture immediately. It was about 4 or 5 months before. Okay. Yes. This is the importance of what we are studying, by the way. eMRCS wants you to reach a spot diagnosis within few minutes, or less than 1 minute. Even in all stations, the 6 minutes that he gives you in the station, in the 18 station, or now maybe up to 20 stations with the pilot stations, he wants you within 6 minutes to reach your diagnosis. Okay, and then he gives you 3 minutes for discussion. This is in part B. Whatever the patient is complaining, within history of 6 minutes or less than 6 minutes, you have to reach a provisional diagnosis for this patient. Okay, next question. Who's there?
I don't know. Who's now?
Dr. Nabaz, I think.
Yeah, I think so.
The term signature fracture is synonymous with which of the following? Is it depressed skull fracture, Lefort 2 fracture, orbital blowout, or oblique fracture of the tibia, supracondylar fracture? Signature fracture.
Sorry.
Would it be 2? I mean B. Lefort 2 fracture.
Okay. Any other answer?
Depressed skull fracture.
Dr. Ismail A, Dr. Jeff B. Okay. What's meant by signature fracture? He wants to tell you that the type or the shape of the fracture will give you idea about the type of the instrument or the type of trauma used. This is exactly the depressed skull fracture. And if you remember, we studied, or we know from the forensic medicine, and what we did study in the 4th year, maybe according to our schedule, about sometimes they use the depressed skull fracture. They can know the type of instrument used and the power of instrument used by the shape of the fracture in the skull. Okay, is sharp? It will give you something like depressed line. If it is blunt, It will give you fracture, broad fracture of the outer and inner pivotal, and that's why we said it is a signature fracture. As the criminal give a signature about the instrument used in his crime by this type of fracture. Okay,
Yes.
this is a forensic medicine, by the way. Okay, next question, Dr. Gada again.
Okay, which of the following is not a form of a primary brain injury? Subdural hemorrhage after being hit in the head with a hammer, meningitis resulting from infected CSF rhinorrhea from a basal skull fracture, a truck driver is involved in a road traffic accident and it suffers an external stretch injury, a man is hit with a baseball bat and suffers a cerebral contusion, a man suffers an intraparenchymal hemorrhage after being hit in the head during a car crash. Not a primary. So I think the primary injury is due to the impact of the injury. And either there is a hemorrhage or hematoma, contusion, concussion. The consequence, I think, like seizure, meningitis, is a kind of secondary or not a primary. So all of them
Yes,
are talking
exactly.
about head injury. Yes, only meningitis.
Secondary infection. This is a secondary infection. Okay,
Yes.
as you say, this is an infection on top of a trauma, or infection of a top of fracture, or infection of on top of a wound. Like the same what I say if I have a wound in skin. So what is a primary lesion is a wound, but what is a secondary lesion is the infection. But does the infection happen immediately when I make the wound? No. I have the wound, bleeding, hematoma, then secondary infection. So the infection or the seizures or any other problem, this is secondary, but the primary, what the injury itself do at the time of trauma, like cutting, hemorrhage, contusion, or even just a concussion. Okay.
Yes.
Okay, next question. I think this is a repeated question. Don't say that this Dr. Fatima's turn.
Yes.
Yes.
I think.
Really, I think even this question was missed from the start or from the middle, and I did it again in the last, so I don't know. Okay, you can go through.
A 65 years old man presents with a new onset left-sided hemiparesis. CT scan of the brain is performed, and this demonstrates a 4-centimeter lesion within the right frontal lobe. It traverses the midline and displays marked central necrosis. There is extensive edema surrounding the lesion. What is the most likely diagnosis? So this is an old age with left-sided hemiparesis. So frontal lobe is involved. So it's option C.
We tracked you.
Why not E? According to the age, as we explained.
Here is he confusing you with some data like paralysis, and then he asks you about the lesion. The same like questions like anatomy. The patient go and paralysis and he can't move his hand, and then he went to the doctor and what is the name of this nerve? Okay, so here is he want to ask about a lesion in an old age patient with a midline shift and central necrosis, so it is cancer, not an abscess or something like this, and surrounding extensive edema, and it's a typical picture of glioblastoma. And the glioblastoma multiforme, by the way. most aggressive type of tumor. Okay, as we said before, the most common tumor or mass you'll find in old age will be the glioblastoma, and most common tumor you'll find in children, which will be the astrocytoma. And this is a picture of glioblastoma, typically displays such marked appearance. And by the way, and this is a very common picture of glioblastoma, surrounding edema plus the central necrosis. Okay.
Yes.
I think we finished. Yes, exactly. This is the idea about the most pediatric CNS tumor are infratentorial, most adult is supratentorial. In pediatric, medulloblastoma was before, but now it is the astrocytoma is the most common, and followed by the medulloblastoma. Okay. Thank you for all. Hope you enjoyed this discussion. I think it's easy. It's about 32 questions, or maybe up to 33 or 34. We talk about 2 hours and 10 to 15 minutes. As soon as the discussion is ready after recording, I'd send it to the group, and hope you just watch it again, or just see it in 2 hours. I think you'll never forget about this question again. Thank you for all. I'll close the recording now.